I would say probably the best advice is to believe that you can do this, that there's more right with you than wrong with you. And your attitude is going to make or break the opportunity to really improve and have a better life.
Welcome to Beyond Theory, a podcast powered by Meadows Behavioral Healthcare that brings you in-depth conversations from the front lines of mental health and addiction recovery. I'm David Condos. According to CDC data, about 1 in 5 U.S. adults have experienced chronic pain. And yet, it can still be hard for them to find appropriate care. But Dr. Mel Pohl is working to change that. So how does he hope to help people find relief without opioids, while changing the way the healthcare field views pain? Let's get out of the abstract and see how this applies in the real world. It's time to go beyond theory.
Hi, I'm Dr. Mel Pohl. I'm the Chief Medical Officer of the Las Vegas Recovery Center.
All right. Well, Dr. Pohl, thank you so much for being with us here at the U.S. Journal Conference in Scottsdale.
Good to be here. Thanks.
Yeah. So let's start with your story, your background. I know, everyone who works in this field has their own personal reasons for motivating them.
It's a very sad story. Okay. I hope your listeners can hold on. No, seriously. I'm a family doctor, and I moved out to Las Vegas in 1979 to be a family doctor. And the person who hired me was the director of a treatment center, drug and alcohol treatment center. And he said, well, you're going to have to cover for me every other weekend. So, I didn't really know a lot about addiction. I didn't really, it didn't call me, but it was interesting. And the field was just developing in 1979. So I got interested in what that meant. And 4 years later, I got sober. So my addiction kind of flourished.
So you were using at that time?
Yeah, I was using, I gave really good lectures on cocaine with my eyes getting real buggy.
Wow.
Yeah. And 4 years later, I just, couldn't go on with the hypocrisy of telling people what to do and then going and getting high. So I got sober in the rooms of Alcoholics Anonymous, never went to a treatment program, and been sober since. So since October 13th, 1984. And relevant to the topic that we're going to talk about today, I developed a chronic pain condition, mainly back and neuropathy of the feet related to nerve compression. And I got interested in what I could do for myself. But more importantly, when the opioid crisis or epidemic really started going, which was in the 90s, I would treat a lot of opiate addicts. And typically they would say, about half of them would say at the end of their detox, they'd say, what are you going to do about my pain? And I would say, I don't know.
Because there's a reason they were started using opioids.
Half the time they were getting them from the doctor or maybe from friends, but they weren't frankly addicted shooting heroin. They were taking pain pills to treat a pain condition. And I just got tired of saying, I don't know. So I got real interested in what could we do in a treatment environment, and got together our management team, and we created a chronic pain recovery program at Las Vegas Recovery Center. It's been around about 12 or 13 years. And, over the years, I've just seen more and more evidence that we blundered when we treated chronic pain with opioids, thinking that was a good idea. And we're now stuck with a bunch of people on opioids, overdosing and dying from opioids. The crisis has hit the news. Everybody's aware of it. There are a lot of interventions that have been done nationally to help, but the solutions neglect the other particularly strong factor, which is that so many people on opioids are really trying to get relief from pain.
Yeah, and they're still dying, even if there's awareness about it.
I mean, awareness, we became aware in kind of a backward way. We saw deaths, and a bunch of people started yelling and screaming. And a lot of those deaths were in groups of young people who were advantaged. It wasn't inner city youth. It was white, wealthy suburban kids who were dying. And that got the attention of the public in a way that other drug abuse did not. And But we sort of overreacted in a sense and said, well, it's opioids are the problem and we have to reduce the opioid prescribing. But we never really got much insight into the fact that people were really trying to get out of pain. And cutting out opioids makes people more miserable. And there's a whole lot of things that happen as a result of that. And we're seeing that now in the last 3 to 5 years since, the CDC guidelines came out to say basically don't use opioids a lot and don't use them in certain ways. I mean, there's a sort of a structure around it. But there are a bunch of people on opioids who have no recourse now, no resources. And that's part of the kinds of folks that we treat, people who can't get opioids or who want off opioids but don't know how to cope with the pain.
Yeah. Yeah. And so looking at kind of a bigger picture view, chronic pain is what you're speaking on here at the conference.
Yes.
You just started alluding to it. How would you describe the landscape of chronic pain? Like how we look at it, how we've been treating it? You said we've had some blunders. How would you describe it?
So what I'll talk about tomorrow is a couple of major misunderstandings. One is that acute pain and chronic pain are in any way related. Acute pain is broken bone, infection, surgical incision. It heals. It's purposeful pain. It's good that you have the pain so you protect the tissue. Chronic pain is an entirely different animal, and most of the medical field has missed that boat. They just don't get it. Chronic pain doesn't reside in the tissue. It resides in the brain. So the tissue that's damaged, or sometimes it's not even related to tissue damage, conditions like fibromyalgia, where there's pain all over the body, is really a brain phenomenon. And we've got a lot of evidence.
It's just mixed signals in the nervous system?
It's picture a cascade inside the nervous system where pain is experienced, and it gets activated. So it's on hyperdrive, volumes up, so that light touch causes pain in the case of fibromyalgia. But, even with people like me who have a bulging disc and nerve compression, the chronic signal hits my brain, and that's really where it registered. And that's really where there's something can be done about pain if we pay attention to what's happening in the brain. Now, opioids are like taking a blanket over the entire brain and causing typically sedation and, a numbing of a pain experience. Not in the long run a very good solution.
But for the patient, that seems like relief at the time.
Seems like a good idea. It seems to the doctor too, because the patient leaves happy, But what seems like a good idea ends up backfiring, and that's really what's happened with opioids. In the long run, opioids end up causing more pain than the person had before. And when we see patients at Las Vegas Recovery Center, we take people off their opioids. We discontinue them. And invariably they say, I can't believe it. I have less pain since I've stopped taking, 100 milligrams of oxycodone and 300 milligrams of OxyContin a day. My pain is not as bad. It's not gone, because if you have a bulging disc or if you have this chronic pain syndrome that we see, it's going to be present, but it's substantially less troublesome when the opioids go away. And there's a couple of reasons for that. One is that opioids cause inflammation of the brain. And this happens not in every single person on opioids, but with long-term use, it happens in what it looks like it's the majority of people on opioids. So, you take an opioid, it works, you keep taking an opioid, and eventually that pain level goes up. The other thing that happens with opioids and other drugs that are abused or people get dependent on is that there's a tolerance that develops in the system. So after a while, the dose of medicine I'm taking doesn't work anymore. The only thing to do at that time, the logical thing is, this is a bad idea, I should stop. It's not what people do. People increase the dose. Doctors are complicit in increasing the dose because what else are they going to do? Or they add a stronger second drug, a long-acting drug and a short-acting drug is pretty typical. And of course, the pharmaceutical industry is behind promoting this methodology. And the whole thing is a house of cards that has come crumbling down.
Yeah. And so you referenced the opioid epidemic. That's been national news for a few years now. What has that changed the way that we view pain? How has that changed this conversation?
The conversation is really primarily about opioids and addiction. The conversation has not, in my estimation, sufficiently addressed the problem of chronic pain. And the real bottom line for chronic pain is that I have a couple of principles of chronic pain that I use to teach people about it. And the first principle is that all pain is real, because there's a highly common misunderstanding among doctors and among patients and among families and among employers that somebody's exaggerating or making up their pain. And the principle that we start with, so people come to us with all sorts of confusion about, is it real, and anger because they've been misjudged, and frustration because they can't convey what's going on, with a life that's spiraling down. So the initial premise that I start out with when I sit with a patient is, I know that your pain is real. However, the pain is not in the tissue where you feel it. The pain is really in your brain. Now, that's where some people really have problems, because they get annoyed or they get frustrated.
Well, because they don't know what to do with that?
Well, partly. My best example is a patient who got real red in the face when I said the pain is related to your emotions and thoughts in your head. She said, "Are you telling me my pain is all in my head?" And I said, "Well, you have chronic headaches. So like, where else would you pain
It doesn't mean it's not real.
No.
Yeah.
Go back to number one, But when we have this dichotomy in our culture and in our medical system where it's either real or it's emotional. What's less real about emotions? And, I've studied psychology and neurophysiology, and there's a clear neurophysiological pathway that causes the pain experience. And it is up in the middle part of the brain. And it turns out that anxiety and fear and anger and frustration and depression drive that pain center so that the pain levels go up. I mean, if you're not defensive, it's pretty logical. When I'm pissed, my back hurts. It seems pretty logical to me. However, if you say to me that my pain is in my brain, I say, no, my pain is right. I can pinpoint it. The muscles are tight. So there is that frustration with understanding. And I think one of the pivotal things that happens in treatment is that people get this. They don't like it, but they say, yeah, okay, I get it. Now what can I do about it?
Yeah. So then carrying that to the next step, what do you do? What's the next thing you recommend?
I described it's like the volume knob is turned up in the middle part of the brain. So we want to do anything we can to teach people how to turn the volume knob down. So if the volume knob is up, anxiety makes it worse. So we teach people how to deal with anxiety. We teach them mindfulness practices. We teach them distress reduction practices, cognitive behavioral therapeutic changes to what can I do when I am gearing up to anxiety, and how can I differentiate a crisis from a bumped toenail, because there's a phenomenon with people with chronic pain, which is called catastrophization. It's like, taking an experience and just making it worse in essence. So we teach people how to turn the lens around. So instead of expanding, it contracts the experience of pain. And there's a lot of emotional techniques that are studied to be able to do that. One of the key things that we teach people how to do is to get moving. Motion is lotion, we say. People are typically, inactive. It hurts to do this, so I don't do this. And that's the worst thing to
perpetuates.
do. Yeah. In fact, the phenomenon of there's a thing called frozen shoulder. So if my shoulder hurts and I don't move it for a while, after a while I can't move it because it is literally frozen. The tissues solidify and scar and hold the joint in place. So the solution for that, maybe you have to go to surgery and get it all cut up. But basically it's, instead of stopping because it hurts, moving through the pain. And I happen to have a shoulder problem too. I got a lot of aches and pains.
You're demonstrating.
If we
have
enough time, I'm gonna talk about it. But so even though range of motion exercises are extremely painful, I do them all the time, and I do strengthening exercises for my shoulders to support the tissue in there. And though it hurts to do it, it's hurt, but it's not harm. And people tend to feel like if I move, I'm gonna harm myself. So they need education. We have physical trainer and a physical therapist and a chiropractor that work with people on their movement beliefs, but also on increasing their function.
Yeah, that's interesting, that distinction between hurt and harm, because we're trained just by our body, and rightfully so, that if something hurts, it's like, oh, I got to stop.
That's right. And that's that sort of perversion of the pain system, because typically if it hurts, if you have a broken leg and the pain signal is hurt, don't walk on it, but if it's a chronic joint inflammation, that is not the case, and that hurt is not a signal to stop. The hurt is a signal that something is traveling to your brain and you have to get moving in order to increase the endorphin levels and dopamine levels and increase the circulation to this immobilized joint, to take away toxins and to increase range of motion. I mean, people who can't move their shoulder, can't put their jacket on, they don't want to go anywhere. As an example that I use with patients. So it's really critical that people buy into the fact that they have to move. You have to get out of bed. And the thinking, which goes along with the immobility, is, I can't get out of bed. Well, how about if I light that bed on fire? I think you'll be up. One of the things you probably can guess is that I don't take this too seriously, because that is one of the key things that I see is it becomes life and death when it's really not life and death. It's just quality of life and sort of waiting for death. That's what life becomes about. One of the other things that we do is put people with other people that have similar problems. There's an incredible effect of being in a group of people who have similar experiences, comparing and contrasting, but the ability to identify, because this is a very isolating condition. Having chronic pain makes me feel different, makes me feel less than, frustrates me, antagonizes me with other people and other people with me. And to be able to sit in a group and be supported for who I am and what I experience, and then move towards a goal is invaluable. And there's data that actually supports that. Most of what I've talked about, there is evidence that goes behind all of that.
Yeah. And so what you're describing, like doing these, motions over and over that kind of hurt, doing mindfulness to rein in the emotional side of it. This is all very kind of long-term processes. And for someone who's used to getting a prescription, popping a pill, that can be hard to understand that this is actually what's going to help. So how do you overcome kind of that cultural rut that we've gotten in, where we expect the instant fix?
I don't have an answer to that sociologically to our culture, because I think what you just described is one of the reasons we're in this mess. Is people go to a doctor for treatment. What is treatment? Treatment is, typically a prescription, and it's something that will work, and it's something that works quickly. How many people take 10 days worth of antibiotics? Most don't. When I start feeling better after 3 or 4 days, I put them away and I forget to take them because I feel better. And the truth is, they work in 3 or 4 days. Probably it's, the last 6 days are just to sort of finish off the little buggers that are causing the problem. But, in the case of using something to make me feel better, they have to be in it for the long haul. And one of the real keys in having a milieu where there are other people doing it is that we have people who've been there 3, 4, or 5 weeks who can say to the newbie, "Oh, I thought he was full of crap too. I never thought this was going to work, but here I am out on the track walking, and I have a walker that I'm not using anymore in my room." You can't argue with that. You can think I'm full of crap, but you can't confound what your eyes see. So the power of that group is really, really essential. And, there's a lot of cheerleading that goes on. I mean, there's a lot of encouragement and motivational interviewing is a skill set that our counseling staff has and that our medical staff has to basically work with people's ambivalence and help them choose something that is on the good side or the healthy, positive side. And then really the biggest challenge is sustaining the changes. Like anything, people who exercise don't tend to keep exercising unless they're hooked into some positive outcome.
Because you think, it fixed it, and so I don't have to do it anymore?
I'm not sure what you think. There's a lot of thoughts, but what happens is if you don't have a sustaining connection with some positive generator, which in our case is the treatment process, But when you go home, if there's got to be something that keeps you hooked in. And unfortunately, human beings forget how bad it was. That's why alcoholics and addicts relapse. It wasn't that bad, but it is that bad. So most behavior change is sustained through connection and continued connection. So we try and hook people up with a connection. For some people, that's a 12-step program, a recovery program. Certainly if they have drug addiction, that's a great fit. Some of our people come in and they don't identify as having drug addiction. They identify as being dependent on the drugs, not being able to be okay without them, but they don't have the same kinds of drug-seeking behaviors and dysfunctional life related to pursuit of the drug because they're pursuing relief. And it turns out that brain-wise, the pursuit of relief and reward, which is drug addiction, are inextricably linked. And with our patients with chronic pain, they are pursuing that relief that is it's hard to pin down. When they get it, then they brighten up. Traditionally, we see people coming in this depressed, disabled, downtrodden way. And, we take the opioids away, we take other sedatives away. Alcohol, of course, is eliminated. And, they wake up and they have, it's interesting phenomenon because they have a life that they didn't see before, and they see the sky that they hadn't seen in years. They also have to wake up to the emotions and the thoughts that have been suppressed.
Because they've been numbed for so long. It's like that blanket you described where it covers everything.
And it's very challenging. That makes the process very challenging indeed.
Yeah. And so you said that at Las Vegas Recovery Center, you have this dedicated chronic pain program that you've built, you developed. Why is that important? Like why should that be more integrated, incorporated into this addiction mental health treatment?
Well, I think what happens is if you don't understand the initial principle that the pain is real and you don't allow for that fact, everything comes apart when you're trying to treat someone with co-occurring pain and addiction. What I hear people who go to other treatment centers that don't specialize in pain, and they're told in group, it's not pain, it's addiction. You're in denial, get with it, as opposed to really understanding that, no, it's both. It's drugs and it's pain.
It's not either or.
No,
yeah.
And it has to be both that are treated concurrently. And, it's not terribly different than integrating trauma treatment in addiction treatment. I know you've talked about that on podcasts before. It's essential to pay close attention to all the factors that are going on in a patient. And if pain is one of them, you need a staff that has expertise in dealing with that.
All right. So for someone who wants to dive in even deeper on this, what would be one book, one resource that you'd point them to?
After they buy my book?
Yeah. So we have your book, Day Without Pain.
Yes.
Which of course sums up a lot of the things we've been talking about.
And I have another book, The Pain Antidote. There's a great CD by a guy named John Kabat-Zinn, Kabotzinn. He's a Buddhist philosopher and psychologist, but he wrote a book called Full Catastrophe Living, and the CD is pain, treating chronic pain. And on it are a number of meditations that are specific for pain. I think that's probably a terrific resource. Another book is Back in Control by David Hanscom. He's an orthopedic surgeon who learned about chronic pain and believes similarly to what I believe, but he learned it from the surgical side. He was a surgeon, and hardly any of his patients got better after he did back surgery. And he finally said, I'm on the wrong side of this process. And he's given up surgery. Now he's just talking about how to heal.
Yeah. And quickly, what's the story behind this book, The Day Without Pain?
That was my first book.
Yeah.
It was just kind of an inspiration from the work that I was doing. I wanted to tell people stories. I wanted to get the word out to try and impact the general public who couldn't access treatment at Las Vegas Recovery. Not everybody gets there. Not everybody is able or willing, but at least to give them a little sprinkle and taste. And we often will send the book out to somebody who's considering coming into treatment. And, I get comments like it really has offered a new avenue for how to proceed in life.
All right. Well, Dr. Pohl, thank you so much for your time. Just to leave listeners with one last thing, what's a favorite piece of advice, something that's meant a lot to you, something that you find yourself passing on that's meaningful to others?
I would say probably the best advice is to believe that you can do this, that there's more right with you than wrong with you. And your attitude is going to make or break the opportunity to really improve and have a better life.
Yeah. All right. Well, Dr. Pohl, thank you so much.
My pleasure.
Appreciate it.
Dr. Mel Pohl is a distinguished fellow of the American Society of Addiction Medicine, a clinical assistant professor at the University of Nevada School of Medicine, and the chief medical officer at Las Vegas Recovery Center. Learn more about his work at drmelpohl.com. Beyond Theory is produced and hosted by me, David Condos. You can discover more from this podcast, including videos of each conversation, at beyondtheorypodcast.com. Finally, thank you for listening, and I hope you'll join us again next time for another episode of Beyond Theory.